Good evening, everyone. You are welcome to this first lecture on Introduction to Endoscopy. It's going to be delivered by Matron PITIKO, Assistant Director of Nursing Department, Federal Medical Center, Abuja. This morning, we had an introductory class on endoscopy, and we had a practical session where one colonoscopy was demonstrated and 3 upper GI endoscopies. And the participants asked lots of questions during the procedure. So, to consolidate most of these stuffs, you need a formal lectures like this, where it's going to be presented, and we'll have an interactive sessions where questions will be asked and they are responded to. So Dr. PITIKO will be presenting 2 short lectures this morning. And,
Chief, which Dr. PITIKO?
Oh, please, you can go ahead. You present your 2 lectures. Go ahead, please.
Okay, sir. All right. Good evening once again, professional colleagues. With privilege, I'm going to give a topic on Introduction to Endoscopy. So let's just take our learning objectives. It's expected that at the end of this presentation, we should all be able to define endoscopy and describe its basic principles. That's one. And then we should be able to identify different types of endoscopic procedures. I know some people used to ask this question, although I don't think it will be here anyway. What's the difference between endoscopy and laparoscopy? Is endoscopy and laparoscopy the same thing? I've seen 1 or 2 people trying to, what's the difference between the two. But I believe at the end of this, we'll be able to identify the different types of endoscopic procedures. And then we should be able to state the common indications for endoscopy. And also, we should be able to describe the role of nurses, which is very, very important before, during, and after procedures. Endoscopy is a minimal invasive surgery, yes, but the role of the nurse is key because she has roles to perform before, which is as important as what she does during, and most importantly, what she does post of these procedures. And then we should be able to apply a standard pre-endoscopy checklist. After now, I think we'll talk about, we know how many of us actually have what is called the endoscopic checklist. Do we really have that? Do we really observe that? What is endoscopy? Endoscopy is a diagnostic and therapeutic. It can either be diagnostic or therapeutic procedure that you use an endoscope to visualize an internal organ. The purpose could be just to examine, that is when you're looking at diagnostic. To be able to diagnose, that's you're looking at diagnostic. Or to treat, which is we are going to now look at the therapeutic. Internal conditions within minimal invasion. That's what endoscopy is. Or that's the little way we can define endoscopy. Or another short form you can also define endoscopy is that endoscopy is a procedure whereby you use an endoscope to diagnose or to treat. And most especially, most at time, the easy way is a just little opening to an organ. What are the types of endoscopy? We have upper GI endoscopy, which is gastroscopy. We have colonoscopy or sigmoidoscopy, which sometimes we call lower GI endoscopy. We have bronchoscopy, which is mostly done by ENT surgeon. I don't know how many of us have actually been opportune to see bronchoscopy. We have cystoscopy, which I know some of us are so much in love with. And then we have laparoscopy, we have hysteroscopy, we have arthroscopy, and we have ERCP. Chief, I don't know whether we do that in Abuja here, sir.
Yes, we do it in Abuja NMPC hospital, though it's very expensive.
Exactly. I wish that this thing gets to, where it will be less expensive so that people will have access to it more, one, and then we'll have more access to it for learning. Indications for endoscopy. What are the indications? As we said, endoscopy can either be diagnostic or therapeutic. So if we are doing diagnostic, it could be that what could be the complaint that somebody will come with that will want you to think of an endoscopy for the patient, because I've seen so many people that will tell you I have ulcer. They don't know the difference, because most of the times when you send them for this upper GI, I think out of 100 cases we have done, you see only maybe like 10 cases that you actually see an ulcer. Most of the times you will not see anything. So most of the times for diagnostic purpose, when a patient has an unexplained abdominal pain, it's also one of the indications whereby you can order the person to go for endoscopy to be able to differentiate, to help you put some markers, as in to redirect you to other things aside from maybe ulcer or tumor and things like that. Then the other thing is GI bleeding, persistent vomiting. Then sometimes, for due to just certain routine, or will I put it, as we always used to say, for those of us that are like 40 and above, you can just do it out of just medical checkup or general routine. And then when sometimes you have a change in bowel habits, it's always good to send them for colonoscopy, because you can never tell until you are able to see, then you can be so sure. And then when you're suspecting ulcers or tumor, as we earlier said, to be able to be sure, instead of always bombarding the person because he has a symptom that looks like the symptom of an ulcer, we keep bombarding them with drugs. Why not send them for an upper GI endoscopy to be able to know, does this person actually have this ulcer? And Chief Bash, you can agree with me that sometimes this tumor, sometimes this one from the bowel duct, pancreatic tumors, sometimes used to give these ulcer symptoms. If you agree with me, sir, am I correct, Chief?
Yes, the pancreatic tumors, usually they present with similar symptoms, epigastric pain that radiates to the back, which you can hardly differentiate from symptoms of peptic ulcer disease. Sometimes when a patient have such symptom and they are being treated for a very long time without any relief, and you do endoscopy, you don't see anything, you have to do CT scan. Surprisingly, you might just see a tumor in the head of pancreas, or you do some tumor markers or some form of enzymes like lipase and amylase. So it's very, very similar. They are common. You are right.
So you see, that's why it's always good when patients come with such symptoms. Instead of you to just conclude is an ulcer and start treating, it will be always good to send such patients for upper GI. Then you should be able to, differentiate and be able to look for other things, instead of just keep on bombarding patient with gestite. And he said, I have ulcer, I have ulcer. Then for therapeutic purposes, you can use endoscopes or endoscopy to remove polyps or foreign bodies, which polyps can, well, let me not talk about that now. But therapeutically, you can remove polyps or foreign bodies. You can do biopsy collection, and then you can also coagulate bleeding vessels. And then you can also dilate strictures. You can also insert stents for where it's necessary. So these are just like few among the plenty therapeutic cases we use endoscopy to do. These just few among them. So let's look at the role of the endoscopic nurse. The role of the endoscopy nurse is actually divided into three, as I earlier said. There is a pre-procedure phase, there is the intra-procedure phase, and there is the post-procedure phase. And of each of these phases, there is what you, as a nurse or as an endoscopic nurse, there are certain things that is expected of you to do, which is very, very important. So let's look at the pre-procedure nursing rules. One is, the first thing you have to do is to confirm the physician's order and the procedure type. Because sometimes, most of the times, if you're not so conversant with this, I've seen so many people, you see the person is asked to go and do bronchoscopy, but once somebody just sees scopy, they will just send the person, say it's endoscopy, go to the endoscopy unit. And most of the times these things are done like in separate places. Although in some other places, you find out that things like all this cystoscopy are things that can be done by the bedside of the patient. But it's always the role of the nurse to be able to differentiate and be able to confirm the order that the physician wants. If it's a colonoscopy, lower GI, what does he want? Is it colonoscopy he wants or a sigmoidoscopy? What does he really want? So it's very, very important for you as a nurse to know the differences in all the scopes. And the ones the physician orders, you should be able to know which one exactly or which of the procedure exactly is the patient supposed to undergo. Then you need to obtain informed consent. This brings me to the question that everywhere you go, you hear people asking, is it the role of the nurse to obtain consent or is it the role of the doctor to obtain consent? So let me just say it here, although we'll have the opportunity for everybody to say what he feels. Obtaining consent is in two phases. One, before the doctor sends that patient, he must have obtained a consent from the patient. And then you, as a nurse, you have to still obtain an informed consent. Why? You need to be sure that consent was taken in the first place. Because that the patient just sends person, you just assume that consent has been obtained. I've seen on several occasions that when it's time now, the patient will say, I don't understand. The doctor did not explain it to me. I'm not doing it again. So your role here is, in as much as the doctor has explained, it is also part of your responsibility or your duty to explain again and be sure that that consent was an informed consent. Dr. Bash, do you agree with me on that?
Yes, you are right. Consent is very important in terms of who obtain the consent. Consent, if one said consent, is different from informed consent. You see, informed consent is a consent that is explained to a patient, and the patient understands the explanation and asks questions, and those questions are clarified. Even the complications of the procedure are explained to the patient. So that is informed consent. It's not something that you just bring a paper and show the patient, sign here, sign there. No, that is not informed consent. You understand? So informed consent has to be explained, and patient asks questions, and the complications are also explained to the patient. So now it is very important, ideally in an ideal setting, anybody who is to perform the procedure should obtain a consent himself, notwithstanding the consent that has been obtained and explained by the person performing a procedure must be verified by members of the operating team, especially the perioperative nurse. Because endoscopy is one procedure where teamwork is fully applicable 100%. If only one person knows how to do it, you are not going to do that thing for a very long time. Everybody must understand.
Be aware.
Yes. So you are right. It's something that must be taken by the doctor and it must be verified by the nurse who is there.
Mm. Thank you, sir. So review patient history, allergies, and medications. Most of the times, these endoscopy patients come as day cases. And then I'm talking to us, the perioperative nursing or the nursing team or the team, because actually it's just a team of everybody, actually. Most of the times you don't ask question, which is very important. You need to review that patient's history. You need to know the things he's allergic to, because it will be so bad that, patient just came for endoscopy and then you start doing CPR over something that, it's easily you can be able to prevent it. So it's always good. It's not just only about what is my own. It's just to clean the scope and then hang the scope and then, oh yeah, after all, the patient is not my patient, it's the doctor's patient. Make we go. No, there are some tiny details that it may just be only you as a nurse that may pick it. So please always review your patient history. Always ask some allergies. And they ask whether the patient has been on certain medications, which you should be able to know. Then ensure this meal per oral, 6 to 8 hours, depending on what you're doing actually. For example, if you're doing an opagia, of course, you ensure this meal per oral for 6 to 8 hours, 6 hours max, because minimum, because of gastric emptying, because of course you are afraid of aspiration. Then of course, but you don't really need meal per oral for a patient that you're doing cystoscopy for if you're not using any analgesia. Yeah, you may not need up to 6 hours, but of course, just in case, what of if you have to, but because mostly you're using a local anesthesia. So if you're doing something that will require the patient to go through some little form of sedation, please ensure this nil per oral status of the patient for at least minimum 6 hours. Then we should verify the boil prep for colonoscopy, which is very, very important, because there's nothing that spoils your scope like going in when the boil is not clean. That's what makes me, most of the times I used to quarrel with the surgeons, because it blocks the scope. The opening of that gastroscope, it just has a very small space where you insufflate from. The chamber is very small. So it's just little leaf that will just go there and block that chamber. And then that's it. Your colonoscopy is gone. And by the time you do that 1 or 2 times, the colonoscope is gone. And these things are very expensive. So please always verify blood prep before colonoscopy. Check vital signs as baseline. Always check vital signs. Always check vital signs. Don't assume and don't be too sure. Ensure IV access for every one patient, whether you're doing local or you're sedating. Ensure you have an IV access so that you don't start running around when emergency comes. Even if you're not giving anything, but ensure you have at least one IV access just in case. And then prepare your equipment. That is like a different topic of its own. That will talk about the scopes, the preparation, how to take care of them. That's like a different topic of its own. But I always used to say this: there is no perioperative nurse without the instruments. You can't be a perioperative nurse without knowing how to take care of this equipment because they are very, very expensive and they are delicate. They are things that can easily spoil. It's just small something like the gastroscope. It's just a small chamber that water doesn't need to enter depending on the make. You just allow small water enter and that's it. It's gone. And then provide psychological support. Very important. Please, for every one patient that you have to do any minimal invasive surgery, any endoscopy procedure for, ensure you provide the psychological support for the patient. Don't assume the patient knows. You know, these days, a lot of people, before you say one, two, they have gone to the internet. They would have browsed a lot of things. They have known the procedure and done a lot of browsing. And they will be telling you some fearful things yourself that maybe you yourself, you have not experienced those fearful things before. So you should know that when they're asking such questions, give them room and provide all the psychological support that you'll be able to provide. Then the post-procedure, let's go to the intra. One, assist the endoscopist with instruments. Like, for example, if we are doing a upper GI endoscopy, always ensure that the mouth guard is there so that at every point, your mind is on that mouth guard. Why? Because at any point, the patient can want to bite. And once the patient bites the scope is gone. So you ensure that in as much as you are assisting, your mind is on the mouth guard, in as much as you're also monitoring the vitals of the patient together with an anesthetist. You know, it's a teamwork. So you don't say, let me just focus my own. My own is only instruments. No. You're assisting everybody. So at the same time, your mind is on the instruments, your mind is on the patient, your mind is on the endoscopist himself, and your mind is with the anesthetist, and your mind is with the patient. As I earlier said, you monitor the vital signs together with the oxygen saturation. If you know how these monitors work, you don't even need to turn to look at it. Once you start hearing some sound, pam, 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 you know when he's telling you that pressure is desaturating. And all of you, in fact, you'll be the one to face it. Before you turn, you see that this patient is desaturating. And that's the work of everybody. So most importantly, the perioperative nurse should always put that at the back of our mind when the procedure is going on. Then administer sedation as ordered, which, depending, as I said, is a teamwork, but most at times is the role of the anesthetist if you're lucky to have a team of anesthetists. Because the ideal, which I had wanted to take the endoscopic suit and the team first. You know, you can see that it's a team that is supposed to comprise of everybody, but sometimes you'll be there and be the PERIOP nurse, you are the technician, you are the anesthetist. But if not, it's supposed to be a team of everybody having what to do. Maintain aseptic technique. At every point, ensure you maintain aseptic technique. Ensure patient safety and comfort. And then most importantly, document findings. In as much as the doctor is documenting, you as a perioperative nurse, you're supposed to have a book for documentation of patients. As the doctors are documenting, you're also documenting, because nobody knows when yawa go gas. So everybody will have his own documentation or documents to bring out. So it's very important. You don't just stand there and then they finish and you just process your scope and leave. No, you're supposed to have a book where you document your patient's name, you document the age, the sex, the procedure that was done, the serology results that your patient came in with, which is very important as a baseline. Peradventure, if your patient needed to come back for with any other reason again. And then you will now document what was seen, what was given, any special incidents or any incidents that occurred within this process that you people had. You're supposed to document it and have it in a booklet. Or these days that most institutions have gone through EMR, there's always a segment for nursing in the EMR. So you should be able to locate that segment in the EMR and make your own documentation, which is very important, because if not, that means you are never part of that procedure, you never knew what took place. And then in cases where you have biopsy samples, it should be handled properly. The formalin inside the specimen container properly documented, and ensure that it's been handed over to the patient, to the right patient, and then together with the right form, and ensure that the sample that was taken is what was written. It's not just, it's not my business. Anything where the doctor write no concern me. No, you are part of the procedure. So you should go through it and check what was written. What was written. The sample was taken where? Is it at the duodenum? Is it at the fundus? Where was it taken? It should be written and it should be labeled. So you're together, ensure that the form has been properly filled by the doctor, and ensure that the specimen, because most of the times you find out that in cases where they have so many cases, some forget to even give the patient the specimen. Please remember, it's one of your responsibilities to ensure that the specimen gets to the patient. Very, very important. So to the right patient, which is very, very important. So the post procedure, transfer patient to the recovery area, which, as I earlier said, if we are taking, we would have known which of these segments is where it is. So you transfer patient to the recovery area, because there must be a recovery area, because recovery is very important. Then you monitor vital signs and consciousness. You don't just carry patients after procedure to the recovery, you close the endoscopy room and start going upstairs. It's wrong. Or you just leave the patient and go. As far as you're concerned, procedure is over. Please, it's very wrong. You need to monitor that patient for the vital signs, even after the procedure, and for consciousness. Because sometimes you can be so surprised, small thing like colonoscopy, there may be a perforation. So if you don't monitor that patient immediately after the colonoscopy, you feel the procedure is all done, everybody goes, you don't even know whether there's a perforation. Patient can just go and come back. But when you finish colonoscopy, you should always ensure that before your patient goes, make sure that at least your patient has been able to pass gas before you allow your patient to leave the endoscopy recovery room. And then for your patients that undergo upper GI, always ensure that they are fully conscious before you allow them to go. And that brings us to where we always say that please don't take patients that come alone. Make sure that your patient comes with somebody. And always ensure that the patient is not going to drive, as long as you are going to sedate the patient. So all this needs to be explained to the patient. Patient cannot drive back no matter what. And you'll be sure that your patient is fully conscious. Monitor back his vital signs before the patient leaves the recovery room. Then you observe for complications. As I earlier said, there could be bleeding, pain, and perforation. I think out of how many years I've been doing endoscopy, I think I've experienced perforation once. And honestly, it was even the doctor's mom that thing happened to in FMCJB in the endoscopy room. We were together with Dr. Dades then. How did we even know that there was a perforation? She was just complaining of pain. And we felt it was after a colonoscopy. And we felt it's normal now. You'll feel better. It's just pain from the distance, the scope. You'll be better. You'll be better. You'll be better. Because she didn't bleed. It was just the pain. And then when the pain persisted, and that was when we are like, what's happening? Let's find out. That was how we now found out that there was a perforation. And that was the first and only perforation I think I've ever witnessed in over how many years I've been doing endoscopy. I think we started endoscopy since 2012. That's the only one I've ever witnessed. Then maintain airway. Very important when it's post-procedure, until your patient is conscious. And then you give post-procedure instructions. One of those instructions to give to your patient is, one, if a patient has undergone upper GI, for example, remember the patient, something went in through the throat. The patient is going to have little difficulty in swallowing, but it's not something that is going to take long. You explain that to your patient. And then some will also be asking, okay, after this procedure, what can I eat? What should I eat first? So these are the instructions that you needed to stay behind to explain to this patient. And then patients that have undergone colonoscopy, very important. Most at times, depending on the boiled prep that is used, most at times, a lot of them lose a lot of water and electrolytes. So it's very, very important for you to stay back and give these post-procedural instructions. And remember, any care that is not documented is a care not given. So you always remember to document your care given. So let's look at the pre-endoscopy checklist. I don't know, Chief Bas, should we go through before questions or can we entertain questions in between?
If they have their questions, they can take it down after the lecture, then we will now entertain the questions.
Okay. So please, if you have questions, you can just be jotting them down so that I don't intend this to be so long and burdensome for us, because most of us are coming from work, and I know these days a lot of us, some will be sleeping now. So God will help us so that we don't, take so long, so that we don't get tired along the way. So let's look at our pre-endoscopic checklist, which is encouraged that every institution should have this pre-endoscopic checklist, which can be modified according to certain things. But this is just the basic that you should have in the pre-endoscopic checklist. One is the patient identity. So you have to be sure that the patient that was sent, that came with the card, is a patient that is in front of you. So you need to confirm the identity of the patient. And I know we all know how to confirm patient's identity. I don't think I need to go through that. Sometimes you don't just say Halima Sadiat, but you can go by saying I'm Ruth PITIKO. You are. The patient will tell you his name. He doesn't even know that you're trying to confirm his identity. It's better that way than say, are you Halima? Or are you this? But I am this and you are. The patient calls his name. You cross-check the identity and be sure. Because sometimes it's funny. You see on the card, maybe the patient's name is written Halima. Halima Dada, for example. And then when you said I'm Ruth PITIKO, you should say I'm Sadia Adinoyi. So you'll be so surprised. Okay, but this is not the name, but that's the patient. So in such situation, you need to be able to confirm and identify that this is actually the patient. She's actually telling you her name. But of course, these are different names. But that name must tally with the name that the card that the doctor sent for that procedure.
Yes,
And then in
especially
short,
like Halima that has 4 names already.
yes, that's why I'm using her, sir. One person gets Adinoyi, he gets Adia, he gets Dada, he gets Halima. Only one person, no. Chief, that's a lot of people like that have those kind of names. So you have to be so sure of that. And then informed consent is signed. Remember, we didn't just say consent signed. Informed consent. And most at times, we just say, have you signed consent? Patient say, yes, I've signed consent. You can make it more better. Like, do you know what you're here for? The patient should be able to explain. Because sometimes I've seen some cases, you see patient, say, what are you here for? She say, I don't know. Doctor said I should come, that they are going to do one procedure for me. I'm like, doctor say you should come, they should do procedure. Doctor didn't tell you the name of the procedure. He said, no, the doctor didn't explain anything. No. You see, there was no informed consent. And that is when you can explain the procedure to the patient and get an informed consent, or you draw back the attention of the surgeon or the physician to that patient to be able to get actually an informed consent. Then allergies checked, as I earlier said, is the work of everybody. So we need to know if this patient is allergic. What is he allergic to? Those allergies needed to be checked. And then confirm fasting, the nil per oral. You don't just ask patient, I hope you didn't eat yesterday night. Of course, he didn't eat yesterday night. But you can start with, what did you take this morning for breakfast? That's the best way to get them. And then the patient, if he actually took anything, will let you know. He would have forgotten because you didn't ask him like a police, you know. So because that meal per oral for upper GI that you are sedating, honestly, is key. Then for boil prep, to ensure whether the boil prep was done, how do you know, or how do you gauge a boil prep that is done? Depending on what you use, like what exactly is the reagent that you use, because we have mannitol, we have column prep, we have so many of them like that. So the first thing you need to ask the patient is, have you gone to toilet today? How many times have you gone to toilet? He will tell you, I've gone to toilet 5 times. So any patient tells me he goes to toilet 5 times, is one indication, is like a red sign for me, red flag to tell you that that patient is not well prepared. Okay, you went to toilet 5 times. So that last one, what did you see? What was coming out? He can tell you it's water. Or he can tell you that small stool. So when he tells you small stool is coming out, then you know that the patient is not yet prepared. But by the time he told you that he has gone to toilet like 10, 15 times, and then what is coming out is water, then at least you can gauge that, yes, the bowel prep was, optimal. Although, when you go in, it will tell. And then you ensure the IV line, and then the vital signs, and then very important, you ask for dentures. That's most especially for people undergoing the upper GI, which is the gastroscopy, the upper GI. You ask for dentures to be sure, and then jewelries to be removed in cases that maybe you need to do a polyp or polypectomy, where the use of the diatemy may be required. Then equipment check. Please ensure you always do equipment check. There's nothing as embarrassing as patient is already under anesthesia. That is when your machine is telling you that it's not insufflating, or it's not sucking, or that it's not, the light is not on. So at every point, as you're doing this, is a pre-check. The first thing to do, Seth, is to ensure that your equipment is checked. Is it insufflating? Is it sucking?
Matron, can you hear us? We can't hear you.
Uh-oh. Can you hear me now? Wow.
Yes,
yes,
go
ma'am.
ahead. Go ahead.
Okay. Can you hear me now?
Yes, we can hear you now.
Okay, now. Okay. So please, possible complications. So one of the possible complications is bleeding, as we earlier said, either from upper GI or from lower GI. One of the possible complications, one is bleeding, 2 is perforation, 3 infection, 4 hypoxia, aspiration, and then sedation reaction, depending on which one. And then remember, as a nurse, one of your role is to be able to detect any of this one early, because it's a team. That's what I'm saying. So it's your responsibility to be able to detect any of these possible complications. And always remember to explain to the patient, please, or after procedure, if you experience bleeding, you can always come back to us. Don't just assume. You can tell the person, okay, after upper GI, possibility of you maybe seeing little blood, but it shouldn't be like something that should take a long time or should be long, because of course, sometimes when we are going in, you may the scope may just do little bruising of maybe certain places that will bring little bleeding, but it should not be something that the patient should continue to bleed. So these are one of the possible complications of endoscopy. So in summary, endoscopy is vital for diagnosis and for therapeutic purposes. Is like is very vital because it's like it gives you a more definite diagnosis. You're seeing, so you're sure of it. So there's no you're not thinking about it. So you're not looking at it and say it may be this, it may be that, because you're seeing it. And then nurses play critical roles in patient preparation, monitoring, and recovery. Very important. The critical roles. You prepare these patients, you monitor them, and you recover them. And then please, the use of checklists. Very, very important because it will ensure safety, efficiency, and quality care. So always ensure that this checklist is always on your fingertips, and then you ensure that it's properly done. And then lastly, I would want to leave us with, nurses are the heartbeat of endoscopy care. So blending skills, compassion, and precision is always our watchword. Thank you very much for listening.
Thank you very much, Matron PITIKO, for this wonderful and exciting presentation. So I think it's time for comments, questions, and contributions. So if you have any questions, please, you can go ahead, identify yourself and ask. Then the question will be addressed. Thank you very much.
Good evening, ma.
Good evening, sir.
I'm Balasani by name. Thank you for the wonderful and eloquent presentation. We really enjoy. Yes, ma. Ma, my question is that, like this boil preparation, how many days can the patient supposed to be well prepared for this boil in terms of boil preparation? That's my first question. And then my second question is that, by the time after you finish the procedure, what is the first line that the preoperative nurse supposed to be done? Are you supposed to be recover the patient, or you supposed to disassemble your instrument and started cleaning?
Okay.
That's my question, ma.
All right.
Yes, sir.
Okay, maybe you go ahead and answer the question so that if any other...
Okay. Any person that has any other question. Okay, so for boil preparation, we have different reagents, or how do I put it, that we do use in boil prep. I know we started with mannitol, and then we stopped mannitol and we came to column prep. So if you're using something like mannitol, it's mannitol that you now say how many days does the patient needs to do this. Because in mannitol, you start the patient with diet. You talk to the patient about light diet. Like, for example, now, if the procedure is going to be done on Monday, you tell the patient to be on light diet from like Friday. Before you start talking about the patient taking the boil prep on Saturday evening till Sunday before Monday coming. So you can see that you're looking at 2 to 3 days prep. But when you're using something like column prep has taken away this issue of starting with light diet on Friday. Column prep can go as good as this patient starts to take column prep on Sunday morning, the first one, and after 6 to 8 hours, he takes the second one, and then he's fine for Monday in the morning for the procedure. So it's actually dependent on what you're using. And sometimes experience too, aside from maybe what the manufacturers say, experience too goes a long way, because sometimes you find out that if you don't, patient that is using mannitol, for example, if you don't give this light diet, don't take vegetable, don't take watermelon with the seeds, don't take this, because of experiences that we have had before, you find out that the patient, after adhering to this, will still come and you still be seeing vegetables that are still on the column. So That is one for that. And then let me answer the second one before we can also take other people's contribution towards that. The second question is, what is your first line? Is it to dismantle your scope or to recover patient? Very beautiful question, my boss. Because you see, in this country that we are, you are the one that will recover the patient, you are the one that will process the scope, and maybe you have like 5, 6, and then you want to quickly process, and then before the other patient will be ready, sometimes you don't even follow the patient to the recovery to check the patient for the patient to be recovered. But your first line as a PERIOP is first of all your patient. As I said, it's a teamwork, but it is a teamwork of everybody. So your first line, because after endoscopy or upper GI, for example, the first thing you do with your scope is you first of all put it in your enzymatic solution, and first of all is not to suck. You understand? You not first of all suck, but when you put it in your enzymatic solution, you first of all blow air. Why are you blowing air? You're blowing air so that if there's any particles, the air you're blowing takes it away. That's you insufflate first. It takes it away first before you suck. Because once you insufflate, if there's any particle at the tip of the gastroscope, it takes it away first before you suck. Then you can hang it, and then your patient goes to the recovery. You still check your patient, put your patients on the monitor before coming back to process your scope. But in a place where you have technician, or in a place where you have the anesthetics, of course, it's better that way. The anesthetist is taking the patient to recovery while you are first of all doing your scope. But remember, that patient is for all of you. So it's not only left in the hands of the anesthetist. So as you're doing that, you can always check on the patient. I hope I've answered this tricky question that Bala asked.
Yes, ma. And then, ma, sorry, there is another question I want to ask. Is there any difference between the scope of colonoscope and the endoscope?
Yes.
Okay.
The gastroscope and the colonoscope, they are two different things. One, they are different in their length. They are different in their size. The functions, they have similar functions, as in the knobs are the same, the color coding is the same, but a gastroscope and a colonoscope and a gastroscope, you will notice them. The difference is one, length, two, the size. They are not the same. Once you see a gastroscope is longer, we are not talking about that, but I would have loved to tell you the CM, but that's another one for another day. The CM for a gastroscope and the CM for colonoscope, their CM is not the same. And is it Brits? I mean, width, how now they say it? It's not the same for gastroscope and the colonoscope. They are not the same.
Thank you, ma. Appreciate.
Yes, sir. If Bash, you have any other thing to add?
No, not really. It's you've answered the questions the way they should be tackled. The boil preparation, yes, of course, you ask the patient not to eat some certain food, high fiber diets, vegetables, some drugs, bread, and so many other things that will remain in the colon. That will make the preparation difficult. Then, of course, a day to that procedure will be taking light juice, that is clear fluids, purple juice, Sprite, clear fluids. And for the scope, the thickness, as you mentioned, and the length, that is the caliber of the scope. For colonoscopy, it's thicker, longer, 160 cm. There are some that come shorter. Then for the endoscope or the gastroscope is 1 meter, and the caliber is thinner. So when you see them, you'll be able to differentiate the two. But by and large, you've answered the questions. Any other question? Any other question, please?
Hello.
Yes. Halima Sadia Adinoyi Dada. Go ahead.
Okay, good evening, everybody.
Good evening,
So
Halima.
I want to first of all appreciate you for your eloquent and mind-blowing presentation. I have learned a lot this evening too. Please, my question is, you talked about after procedure, the priority is the patient, not the instrument. Agreed, ma. But what if in a situation where the endoscopy suite does not have a hanger? Like when you receive from the physician, when you receive endoscopy, the gastroscope from the physician, you are expected to blow air, suck, and hang, then take care of your patient before you come back for processing. But there are quite some endoscopy suite that doesn't have hanger for scope. Like you don't have any other option when you receive the gastroscope after blowing and sucking, you just have to take it to a processing unit. And maybe you don't even have another nurse as an assistant. So can it be excused that at that point, the doctor help you take care of the patient while you go and take care of your instruments?
Yes, Halima, as I said, it's a teamwork. As I said, the other topic we're going to talk about is a team. It's actually a teamwork. In a situation whereby it's like that, of course, the doctor should be able to help you because actually the priority is the patient. That's one. In as much as the instrument is very important and very vital because it's delicate, very expensive, which any small parang once it's spoiled, it will mean you're not having to do it. So, in such situation, you can also weigh it. There is some this one that you do that the way the patient is acting, you will not even remember to go near your scope. And there's a one that you do that, the patient is fine. Of course, they can just help you have a look at the patient while you take your scope for processing if you don't have where to hang it to attend to your patient. But remember always, in as much as your instrument is very vital and very important to you, the patient is always your number one priority. Because without that patient, there won't be the need for you to use the scope. And that patient is a life that must be well taken care of. It must not be heard that the patient came for a day procedure and something happened to the patient. I hope I've answered you.
Yes, my boss. Thank you very much, my boss, my mentor, and my mother.
Halima.
Well done, ma. It was nice having you on board this night.
It's a privilege.
Any other question? I know people are sleeping.
Yes, I have another question.
Oga Bala, my boss.
Sorry, ma. So, immediately after you finish the procedure, so the next thing you do is to remove the air bubble to put the scuff inside the enzymatic solution, or what?
Yes. Immediately after the procedure that the doctor comes out, the first thing to do is to put your endoscope, other gastroscope or colonoscope, inside the container that contains the enzymatic solution. The first thing to do is to insufflate, not suck. The first thing to do is you insufflate. As I explained, the essence of you insufflating is that where that insufflation channel is very small. Maybe when you take your time, you have a look at it. In fact, you don't even know that there is an opening. But so it's as small as a leaf.
Yes, ma, I saw it today. I saw
So
the two
small leaf
opening
can
today,
just
yes.
block it. Yes. So it's always good to insufflate first before you suck.
Thank you, ma.
Thank you. Okay.
I believe we can take the next lecture.
Okay, sir.
I know it's a very short one.
But you're still sharing the other slide.
Yes, I'll share the other slide now.
Okay, thank you.
Can you all see my slide?
Yes, sir.
Okay. Hassan, are you
Yes,
with
sir.
us?
Very much, sir.
Okay, Matron PETIKO, please, you can go ahead.
Okay. Thank you very much. Thank you for listening and giving me much attention. So we are going to go to the next one, which is the endoscopic suit design and the team. Because, of course, the endoscopy has to have a suit and it has to have a team. So, an endoscopy suit must ensure 1, safety, 2, efficiency, 3, infection control. These 3 things is one of the it's like a key or a key point to you having an endoscopy suit. One of it is that you must ensure safety. The suit must be safe, and it must be efficient, and it must have an infection controlled area. And then the patient flow. There's a patient flow, there's the equipment flow, which is very important. The patient flow is clean, procedure, recovery. On a normal good day, for you to have an endoscopic suit, you're supposed to have where it's clean, which is like a reception area, where you first of all collect this patient, where you first of all receive this patient, where you first of all do this your pre-endoscopic check, and then in cases where you need to change the clothes, the patient changes the clothes. In a place where you need the patient to wear a patient's gown, he wears the patient's gown. That's from the clean then to the procedure room, and then from the procedure room is to the recovery room. That is the movement flow of the patient. It's not supposed to be like everything done in one place. No, it's not supposed to be like that. You're supposed to have a place just like room and parlor and kitchen. So the clean, the procedure, and the recovery. The same thing with your scope. Your scope needs to be a one-way thing. You are not supposed to keep your clean scope in the same place with where you are processing your scope. In an ideal setting, and it's like a flow. It's a one-way flow. You're not supposed to you're processing here, you go procedure, you come back to processing here, you go back. No, it's like a one-way. As this place you're processing, you're doing procedure. The other one, the data scope is going this way, this other side is out. Another clean scope, process, clean, out. As in, it's not supposed to be a two-way movement. It's just supposed to be a one-way flow. And then, of course, you need to have a dedicated multidisciplinary team. As we said, we get to know who and who is supposed to be part of it. So this picture is just showing us, I just want us to have a look at it. We'll still come back to it 1 or 2 times. There are certain things you observe when you're setting up your endoscopy suit, and then where should the monitor be? At what level should the monitor be? At what level should the screen be? Where should be the place where the endoscopist stands? Where should the nurse stand? And where should your anesthetist stand? That is this is one of these first screen that we're seeing now. It's telling you that the screen needs to be at the eye level of the endoscopist. It's not that the endoscopy needs to be turning his head because of the ergometrics. Very important. is facing the screen. And then you yourself, you can see how the nurse is. You can see the issue of the mouth gag. You can see her. Her attention is on the mouth gag. You can see her attention is on the mouth gag. In as much as the endoscopist, his attention is on the screen. Her attention is on her mouth gag and on the patient. Next screen. Yes. This is where you have like, it's just like not only one. You can see how it is. This is just how an endoscopy suit should be like. You can see nobody is turning the neck. The endoscopist is not bending. He's not lifting his head up. The screen is at his level. He's looking at it at his own level. And you can see the distance between every other thing. Where the endoscopist is standing, where the patient, the bed, where the patient is. This will all get to know the dimensions. Let's go. Next screen, sir. Okay, so now the suit zoning and the space design. As I said, normally you're supposed to have where it's called the reception area, or the pre-procedure area, or the clean area. And then you are supposed to have the procedure room. So on a normal norms, on the standard, your procedure room should not be less than 25 to 45 meters square on a good norms. It should not be less than this. That's the procedure room, because you know the procedure room will contain the scope, will contain the monitor, and there should still be enough room or enough space for movement in between teammates. That if you have any reason why you need to move around or you need to pick something, there should be enough space. And that's why we have this as the standard. And then the recovery bars with monitoring. As I said, we have reception, we have the procedure room, and we have the recovery room. So in as much as your procedure room, this is the measurement I said, and it's supposed to have the monitors, have to have the space for your bed, have to have the space for the anesthetic machine, have to have a space for the oxygen, which most of the times these days is supposed to be piped. But in case it's not a piped oxygen you're using, of course, there has to be space for that. And then there has to be space where the scopes are hanged, clean scopes are hanged and are tacked. Clean scopes hanged and tacked, checked. You know that these are clean scopes that are ready for procedure. Then with your suction machine, and there should be enough space for movement for everybody in that place. And then you should also have another monitoring in your recovery room where this patient goes to and they are being monitored. It's not when they leave this place, they go there and then they are not on monitors. No, your recovery room should have monitors, and your recovery room too should have beds or stretchers, you know, that have rails for monitoring these patients. And then we have the scope reprocessing unit, which most of the times all of us used to put them in one place, but actually it's not supposed to be so, because as we said, the workflow is not the same. It's a one-way movement. You move from here, the next. It's not moving front and back. I believe we know why, because of infection control. But I know most of us, you know, in the settings we have, where you're processing the scope is where you're hanging the scope, is where some of us even recover the patient, is where the patient changes. It's not supposed to be so. So you are supposed to have the scope reprocessing unit where you have, depending on how the scope is being reprocessed, there are places that have scope processor, and there are places that you process the scope manually. In any way, they're supposed to be where you're supposed to process it. In where you have the scope reprocessing unit, then you have the processors, what you use in processing the scope, and then how these scopes are being hanged after processing. You know, it's a process of processing. It's not just, if you're using the manual, it's not only just to clean, you also dry. You also allow water to drip. You also allow air drying, and you also allow for air check. Okay, then we need to have what is called the store. the clean, the dirty, and the equipment. They should also have a place like a store where these things are kept. And then you should have the staff changing with locker rooms, because the staff that are coming, they need to have a changing room. We're talking about the zoning now and the space design for the suit. Next one. Then the infection prevention by design. One, as I said, is a one-way workflow for scopes. Your scopes are meant to be hand-checked with dates when they were used and when they were processed, with a tag written checked, telling you that one, the scope is ready for use because it has been processed, it has been checked. And then you have the decontamination, which, as I said, it could either be manual or the one we used to do. As I said, you first of all decontaminate. I don't know what we are using, but that's why you find out that if you are using manual, you have like 3 to 4 different waters. In fact, you're supposed to have 4 water if you're using manual. The first water, which normally contains the enzymatic, is the one for decontamination, because what the enzymatic solution does is decontaminate. And then before you come to your clean water, because once you decontaminate, you come back to your clean water before you go to your ammonium, which is like virucidal things, you go in there and then you go back to a clean one. That's why I'm saying you need to have 3 to 4. Then you come to drying. After drying, because sometimes it's not just when you finish, you just hang and you start the next procedure. No, you dry the scope. The water needs to drip down and you need to clean it. Then the next thing you need to do again is check the pressure, the air check. You must always, after each use and after each cleaning, you have to do the air check on either the gastroscope or the colonoscope. And then we have the negative pressure, which is in the dirty zone. The dirty zone, as far as we are concerned, is when you remove the scope in that processing room. That's where we call the dirty zone. Once the scope is processed, the next one, which is going to be the positive pressure or the procedure rooms. And then remember, if we are talking about infection control, that means you have to put in place at the back of your mind, when these things are done, what kind of dose should you have in your procedure room? From the clean area to where the procedure is, what kind of dose should be there? Most at times, the dose we have is like those in our bedroom, but that's not what you're supposed to have. What you're supposed to have is those that are, you just push the go you, or the best is this sensor dose. Your dear, it opens and you go. You're not touching anything. Your hand is free. You are not touching the door. You're not touching anything. So even when you're coming out, you're not touching anything. The same thing with the taps. Most of the things we normally used to forget is our shanks. Actually, our shanks are not supposed to be shanks that are like taps that you need to open with your hand. No, they're supposed to be things that have pedal or body sensor. Now, once you're done, you don't need to use it, because sometimes when I go to places and I see that it's tap, how do you close it back when you are done? Your hand must touch, and then you will know that, of course, infection control is not there. So when you're setting an endoscopy suit, these are the things you put in place. One, the shank. The shank has to be the one that is not a tap. It has to be what you use with your feet to do. And then the dose is not where you will be using your hand to open handles, because it's not correct. The normal theater dose. And also at the same time, look at those with airflow. How it's going to be when the door open, how much of airflow can go in. Next slide. Then the core equipment. We have the endoscopy tower with monitors. And this is different depending on the make. We have Fuji, we have Olympus, we have Castors, we have all these Chin, all this China. There are so many makes. But one thing is key with those makes that you need to know is that for every endoscopy, there must be a tower one, there must be monitor, there must be the CO2 insufflation, and suction. And most at times, or of all times, they always have what we call the color coding. And once you are well familiar with color codes, you don't have issues with any tower, no matter the name of the tower, because all towers must come with this color coding. So once you know the color coding, you're good to go. Then coming to scopes, we have the gastroscopes, we have the colonoscopes, and then we have the duodenoscopes, which bronchoscopes. We have the flexible, we have the non-flexible, we have, I remember when we are still doing cystoscopy using the rigid the rigid cystoscope, you know. So all these scopes, there is what is called the color coding, which I'm just trying to say. I just want to, it's just like a little introduction. I think there will be topics where we'll look at those things, having to look at them and looking at every part. There's going to be something like that, but I'm just trying to, on a general knowledge. For example, like the gastroscope, you have the red and you have the blue. Once you hold the knobs, you see that there's always a red and a blue. Blue is a sign of air, or it's a sign of the sky. That's water. So once you put that at the back of your mind, when you see the blue, you know what the blue is meant for. The blue is meant for what? Sucking. Then when you come to the red, you see that it's like red fire, right? So that is for insufflation. So that's the same thing. Those color codings, the knobs to the bulbs on the gastroscope, on the colonoscopes, the color codes are there. So you should always know which color codes to fix to which one. And then you will not have an issue at all. And then there is, depending on the make of what you're using, the gastroscope or the colonoscope, the connection of the tip to your tower, very important. There's where it's called, there's an air chamber. If you see them, depending on the type, you see that there are like three. One is big, which is the one that is connecting you, that is giving you the scene. The other one is something long. It's water that comes out of that place. That's water chamber. And then there are some small ones. Well, I wish I had a scope with me to show us and differentiate these things. Anyway, we'll get to that. Then accessories, of course, we have the biopsy, forceps, the snares, the clips, the retrieval devices, which I wish I had them, but I believe one of these days we get to see them if we have not seen them, which I believe all of us must have seen them in one way or the other. And then we have the SRU, which is the sinks, the leak tester. Very important, as I said, always ensure to do leak tests after each. Then the drying of cabinets. The drying of cabinets. Then the recovery, the monitors, the oxygen saturation, the suction, and then the emergency cart. Remember, in every of your recovery, please ensure you always have that emergency tray. And that emergency tray, always ensure that everything you need is always in that emergency tray or emergency cart. Very important in the recovery. You can never tell. In fact, since I've started endoscopy, I've lost one patient just from endoscopy. It was just like drama. We are like, it was an acting. And that is before you know it was CPR. Before you know it, patient don't work. So very important. You need to have those things. And every other thing that needs to be there needs to be in that card. Don't assume. Don't be so sure. It's not only endoscopy. Please always ensure that. Next slide. Chief Bash, are you sleeping? Okay. So the team. So we have the team composition. I'll just be fast, so that we can all go and rest, actually. The team composition, one, we have the endoscopist, who is the lead of the procedure. And then we have the sedationist, which, as I said, we could have an anesthesia, or a trained physician that will give anesthesia, but most at times in a good team, you're supposed to have a team of an anesthetics. And in as much as we are going for training, it's always good to also have your anesthetics as part of the team, which is very important because the team is complete. And then you have your circulating nurse, whose duty is to coordinate and document. And then you have the endoscopy nurse. And you can also have a tech support. A tech support is who processes the scope. So you can see is some places where the nurse is the circulating nurse. Excuse me, she's the circulating nurse, she's the endoscopy nurse. So you can imagine thinking of even having a take. No. So in a good one, we're supposed to have like two nurses. That's the circulating nurse and the endoscopy nurse. And then the recovery nurse, who is going to recover the patient, because each person has a role to play. And then you have the reprocessing technician. And then, of course, you can have your supporting staff, which is the porters, the biomedical, the ICT, the IT people. So in a composition of the endoscopy, we're supposed to have a team. As I've listed, we are supposed to have a team of like 7 people minimum. But most of the times, you see that maybe it's just the endoscopies with the nurse, and the one we try go get the anesthesia. But it's always good to be a team. This is just ideal team. Next slide.
I'm awake.
You are awake. Thank you, sir. Okay, so the workflow and the safety. You know, we talked about the pre-list or pre-endoscopically checklist. And then we have here the workflow. We have the pre-list hurdle, the rigs, the anticoagulation, the equipment. This is like just a workflow safety that you ensure that, you know, you check all those things. Then the time out before each case, you are supposed to have a WHO checklist, which is what we just did, which is the endoscopy checklist, then for each one. And then there's always what is called the room turnover, which most of the times should not be more than 15 minutes. But you know, sometimes when you have plenty cases, your room turnover, you can turn it to 1 minute, which is not supposed to be so. On a normal good day, you're not supposed to have a room turnover less than 15 minutes in a place where you're using only one scope, because you're supposed to use 10 to 15 minutes to process one scope. So, but in the places that maybe you have like 2-3 scopes, you can afford to have 10 minutes room turnover. Why? Because, you know, patient is moving, the place is cleaned, and then the next patient is coming in, the checklist is done, then before the procedure. So there's no how you should have less than 10 minutes room turnover. And then the resuscitation equipment and drills. Radiation safety, if in places where you do ERCP, you always ensure that there is this radiation safety. Next slide. Quality and training. So we have what is called the scope reprocessing SOPs and audits, which is very important that you should have in every unit is supposed to have this. What is called the scope reprocessing SP, that is standard operation practices for scope reprocessing. And the audit, one among all, one or two, I'll just give like 1 or 2 of this is one. You should always ensure that for every scope, you do an air leak check. And then secondly, you need to be sure that for every scope, there is the check label on the scope. That means it has been reprocessed. And this checklist checked label used to come with the dates. That's the date that scope was used and the date it was reprocessed. And then you see the check. That's how this audit go. And with this audit, it also goes a long way. It's supposed to come with the nurse, the name of the nurse who used it, the name of the nurse who reprocessed it. So by the time you're using that scope and there's any issues, you already know when it was used, you knew which nurse used it, you knew which nurse processed it. That's one of the SOPs and the audits for scope reprocessing. And then you also need the sedation protocols and discharge criteria. For each patient, you should know what kind of sedatives can be given to that. There are protocols to that. And there is also a discharge criteria. There are cases that you just do only upper GI. Instead of asking the patient to go, you may end up having to admit the patient. I've seen like 1 or 2 situations whereby we just did only upper GI, we ended up admitting the patient. So it's not just about you're done and then all you know is your work is done, you leave and you just leave your patient. The patient needs to be discharged, and the discharge has to have a criteria. The patient needs, there are like a checklist for this thing. Tick consciousness, tick pen, tick passing of gas, tick able to swallow saliva, tick. These are like kind of discharge criteria before you know that yes, this patient is able to be discharged or this patient can go. And then we have quality indicators. The ADR, the cecal intubation, and the withdrawal time. They are like indicators. And then you have the regular staff training and emergency drills. Very important. It's always good that at every point in time, your staffs are always trained. There's this training and retraining because new things keep coming. So you don't always stay and feel like an island, you know everything, because new things keep coming. Because I remember then you can easily soak your spirits on a cotton wool and go to the tip of the gastroscope and clean it. But do you know, after some time, we later learned, or as research goes on, we later learned that spirit you use to clean the tip of the gastroscope, over time, you get that place to get blood. So what should you use to clean? So if you are not doing regular staff training and emergency drills for your staff, you just keep the knowledge of 1920, and then you feel like you are what do I even put? You're a champion in this thing. You'll be left behind as the trends are going. So, which is very important for staff training and retraining. Conclusion. A well-designed endoscopy suite combines patient-centered workflow. Also, it puts into mind infection control, adequate equipment and technology, and then most importantly, skilled, coordinated, multidisciplinary team. Very crucial. That's to say, to have an endoscopy suite that is well designed, it is starting from the patient-centered workflow, as in starting from the workflow. Where is the clean area? Where is the procedure room? What is the space? What is the distance between the bed to the monitor? What is the distance between the bed to the anesthetics machine? What is the distance between the endoscopy standing and to the screen? What is the distance between the endoscopy and his angle at which he's holding the gastroscope? Down to how does infection control happen, to the processing of your scope, to the reagents that is being used to process your scope, to the methods being used to process your scope, and then to adequate equipment and technology. Not using 2020 machines when we are in an advance that you're to look at the monitor is not giving you a beautiful picture of what you're seeing. I never finish shift. Don't say me, I tell you, I say thank you for listening.
It's an error.
So very importantly, you must have your skilled, coordinated, multidisciplinary team that will be able to ensure safety, efficiency, and high quality care. Thank you for listening.
Thank you very much, ma.
Thank you very much.
Thank you.
If you have any questions, comments, contributions, go ahead.
Okay, sir.
Please go ahead with your question.
Okay, ma. Okay, sir. Ma, thank you for the wonderful presentation. In case of this, cough reprocessing,
yes,
you say one way dirty clean. Like now, if I finish the procedure, immediately I finish, I remove my scuffs. I have to move to where I will clean it.
yes.
So immediately I move to the dirty. Is it a dirty corridor or
To the processing unit? You know what I
okay?
mean by one flow is, it's not
Yes, ma'am.
like it's not supposed to be like a small place that from here you just come here. From here you are moving. You know the movement is a one-way
Yes, ma'am.
movement, just
Movement,
as you
yes.
have in the theater.
Theater, yes.
Yes, it's a one. You're moving to this other angle to where you're processing. You're coming back in another route to come back to the clean. You're not using the same way you pass with your dirty scope to process and use the same route to come back. No. You're taking one way because from here you're going just as the way you're using your dirty corridor from the theater to the Swiss room. And then from the Swiss room, there's another door that leads you to the clean area, right? Taking you
Yes,
back
ma'am.
again to the clean suit.
To
But
the
you're not
clean
using the
suit.
same dirty corridor.
Dirty corridor, yes, ma'am.
Yes. So it's the same thing with the endoscopy processing. You're not supposed to have the same workflow as it's not supposed to be your movements where you're picking your dirty scope for processing should not be the same road you're coming back.
Coming back, okay. Thank you very much, ma'am. And then my second question is that what's the meaning of the SRU?
SRU.
Yes.
Okay, let me look for
Under core equipment.
Under core equipment.
Yes, ma'am.
Okay. This SRU is just like telling you those things that you need to check in a place. That's where you can see that's where you have your shank, your leak tester, your drying cabinet.
Okay.
I don't know whether you understand.
Yes, ma'am. But this leak tester, what's the meaning of that leak tester? I don't know.
It's
The leak
inside
tester.
it's inside the gastroscope. It
Okay.
comes with it. It's one black thing that has it's like a gauge.
Okay.
That comes with like a clock on top
Clock.
with one
Yes,
black
I
thing
saw
down.
it. Yes.
So that's the leak tester.
Okay, that's the leak tester.
Yes.
Okay. So how do you test it?
The leak tester, it has an end. From the black, it comes down to one end. Then under your gastroscope, there is an end that you connect it to it after you are finished processing. Then you now inflate it. Then you see that the time that is there, it will be going up. You get to 180. Once you get to 180, you stop pumping, and then you hold on to see. The leak test there is that when it gets to 180 and you stop pumping, it's not supposed to shift again.
Okay.
But by the time you start shifting, that means there's a leak.
Okay.
So one is at 180, it's supposed to stop like that. Yes, it is not supposed to reduce. So once it starts reducing, you know that it's leaking.
Okay. Thank you very much, ma. Thank you.
Thank you, boss.
Yeah, thank you.
Well, if you go to the practical session, you can also ask for demonstration of all these things. When you go to the endoscopy suite, you can ask the PERIOP to demonstrate all these things.
Yes, sir.
More questions, comments for those that are awake?
Truly, for those that are awake, not be smart in chief. Because the time is fast gone, wallahi.
Oh, some of them can stay up to 1 a.m. Although it's not lecture.
Yeah. Oga Hassan, are you still here?
Matron
Stop.
picked his part, so it's expected that he's sleeping by now.
It's not easy, oh. Wallahi.
Okay, so thank you very much, everyone. Matron PETIKO, which lecture do you have tomorrow?
Okay, tomorrow we are going to, you gave me topics, sir.
Yes. Okay.
Yeah, so I'm still working with those topics you gave me to present.
Okay.
So I'm hoping that tomorrow maybe we'll look at the endoscopic equipment and instrumentation.
Okay, that is fine. We also have a lecture with Dr. Abdul Karim Lukman, gastroenterologist from Ariwa Hospital tomorrow. I'll share the link. We also have a physical class with Dr. Yusuf, he's a gastroenterologist also with Aminu Kano Teaching Hospital. It's going to be a physical class tomorrow.
Okay.
Yes. So for the online class, I'll share the link on the platform. While the physical class, of course, it won't. It's just for those who are here presently. Yes. So thank you very much, everyone.
Thank you very much, sir.
You want to say something?
No, I'm done, sir. Thank you.
Okay.
It's highly elaborate, sir. I'm enjoying it.
Okay.
Yes, sir. Thank you very much, ma.
Thank you.
Thank you. Thank you, ma. Thank you.
So thank you very much, everyone. We are going to continue
Okay, thank you, sir.
tomorrow. In the absence of any other comments, we are going to call it a day. And good night, everyone.
Thank you, sir. Thank you very much, sir.
Thank you.
May God reward you. Thank you, ma. We appreciate.
Thank you very much.
Thank you, ma. Thank you, ma. All right. Good night.
Good night, bosses.
Good night.